Hello, everyone. My name is Rosalind Daniels, and I'm president and founder of BlackHealthMatters.com. And I am thrilled to be here today. We have an amazing guest, Dr. Paul Underwood, who's going to talk to you about heart disease. So if you're a person of a certain age, this is the show for you to watch. But before we start, we want to acknowledge the Floyd family and just give them a moment. Let's think about them for the sacrifice that they are making for our country and for the world, how they are demonstrating just undeniable courage at this turbulent time in our country's life. So if we could just take a moment to think about them. Before we start, I want to thank my team. A lot of people think that I do this by myself, and that is just really impossible. As you know, we have BlackHealthMatters.com, which is the leading health and wellness website. We are in the community more than 20 times a year with patient education programs. We have a newsletter. We do social media, and I cannot do this by myself. So I want to thank my team. Leslie Fontenot has been hosting for the last couple of Wednesdays. So I want to thank her. I want to thank Nigeria, Dana, Michaela, Colin. I want to thank you all for everything that you do to hold us up and support this brand and our mission. Before we start, I also want to share, I am so excited to talk about the upcoming Black Health Matters Summit. It is going to be virtual. Go to BlackHealthMatters.com on Monday to register. Now, some of you have already started to register, but we're going to have to ask you to re-register so that you can get into our summit. It is free, and I promise you, it is going to be the most amazing experience that you can imagine. Why? Number one, I've got an amazing faculty. I have a world-class faculty that's coming together just to talk about African American health, whether it be heart disease, mental health, maternal fetal medicine, HIV, AIDS, and PrEP. We have it all. So it's going to start at 8:30 in the morning, and it's going to go to 6 p.m. So we do hope that you can be with us all day as we talk about these great, important facts relating to wellness and chronic disease management. So please join us. Additionally, this platform that we're using for our summit will have avatars and have animation, all of that so that it's easy to access, but you will actually feel as though you're in a conference. You'll have a lobby that you'll walk through. You'll have an auditorium that you'll sit in while you're watching the presentations. We'll even have an exhibit hall. You'll be able to chat with some of our partners and sponsors. So it really is going to be unique. It's going to be the biggest virtual health event that has ever been created by the African American patient, caregiver, and family. So you won't want to miss it. We need you to participate to demonstrate to the world that Black health matters. Now I'd like to introduce you to Dr. Paul Underwood. And I'm going to ask Dr. Paul Underwood to really say a little bit more about himself. He is a former president of the Association of Black Cardiologists. He is a leading physician. He is completely compassionate for the African American population, the people he serves. And, we're just honored to have him. So good evening, Dr. Underwood.
Good evening. It's certainly a pleasure to be here. I'm certainly excited to hear about the summit myself. It's been such a long time since the last one was. I can't wait for this one to occur.
Well, Dr. Underwood was one of our first presenters when we first launched our summits. So we are growing and we're doing well. So thanks for being a forefather.
It's nice to think of it that way. I know a lot has happened since the very beginning, and I remember just talking with you even before Black Health Matters came into existence. And so the platform has really certainly taken off, and it's really always been a pleasure to work with it.
Thank you so much. So I want our audience to learn a little bit more about you because you are such an amazing role model. Tell us, what led you to pursue medicine?
Well, thanks, Rosalind. I don't think that what I did was anything more amazing than what anyone else would do or could have done. But it's really getting into sciences, and as a high school student, understanding how much you like math and sciences, and then pursuing that once you go into your undergrad career. I was, told that I do well in science. I like to help people. So medicine has allowed me to put the two together. And certainly for cardiology, it's taking care of sick people, people who can be extremely ill at times, but understanding how to best manage them.
Now, I'm wondering, do you happen to have a statistic about how many African American cardiologists there are? And I ask that because we know that heart disease is the number one killer of most Americans. And so how often are patients going to really be interacting with African American cardiologists?
Well, it's kind of a double-edged sword there. So hopefully most of us aren't going to have to interact with cardiologists at all, which is good. But unfortunately, if you were looking for African American cardiologists, they are relatively rare. I think overall African Americans are about 3% of the physician population, and cardiologists would be somewhat less than that. So it may not be that everyone has direct access to a Black cardiologist, but know that the Association of Black Cardiologists is there teaching others, not just Black cardiologists, but teaching the whole cardiology community and the primary care community on what can be done to help people, particularly people of color who may have cardiovascular disease.
Excellent. Now, please tell us about your education. I understand you are a Morehouse man.
Absolutely, absolutely. So I'm originally from Knoxville, Tennessee. My mother was a math teacher at Knoxville College, so I grew up on the campus of Knoxville College. Certainly, when it was time for me to go to school, for me to go to college, I wanted to get out of Knoxville. Atlanta is certainly a booming city that is very close to Knoxville. Morehouse, I thought, was the premier school for African American males. I will say that my three sons also attended Morehouse, so I'm very pleased. I'm pleased with that as well. I still feel the same way, but getting there for a pre-med education was extremely important. I think at that time, even though just out of high school, I didn't realize that having David Satcher and Louis Sullivan there on campus to interact with through our Health Career Society would be so influential in me, particularly in terms of community advocacy. And as you well know, the education structure that Morehouse has for the sciences has very high rigor. So, learning sciences, learning, about the arts, as well as understanding how to become a community advocate was a very important component that I gained by attending Morehouse. And I would recommend that others do the same.
Terrific. Now, if we could just fast forward a little bit to your tenure as president of the Association of Black Cardiologists, what are some of your fondest memories and what are some of the things that you're most proud of about your tenure there?
Well, I think the Association of Black Cardiologists has been a wonderful organization to me throughout, from the very beginning up until this moment. So starting off as a trainee in cardiology, learning cardiovascular disease, the opportunity to discuss, mingle with, or to be in sessions with practicing cardiologists, Black cardiologists who were in the field across the country, many different fields, helped to focus me to understand what I should focus on during my training. So understanding what they were doing in practice, the different types of cardiology practice, say whether it's going to be interventional cardiology or heart failure, electrophysiologist or preventive cardiology. So there are many forms of cardiology. Certainly there are many geographies throughout the United States. And then there are many practice situations such as academic cardiology or clinical cardiology, or what I'm doing now with industry cardiology, working with Boston Scientific, that there are many different avenues to explore, and the association has helped to develop those or to bring those to my attention as a trainee. Now, once I've been in practice, I've had the opportunity to participate in education events. So educating clinicians through our continuing medical education programs has been very important. Advocating for communities and patients to the Hill, the Congressional Black Caucus and other advocacy groups, whether they're going to be state, local, or national, has been an important component of the Association of Black Cardiologists. And right now I've been very involved with the Community Programs Committee of the Association of Black Cardiologists. So delivering community education across the country and trying to break down some of the scientific knowledge that we know of cardiology so that people can actually benefit from it and know what to do and how they can manage their own illnesses or their own risk factors has been an important component as well.
And that's why we have you here today. There's so much concern, and we're seeing so many disparities that exist in African American health. And COVID, I guess, has basically helped to amplify all of these issues. Not that they didn't exist before. The rate of death and the prevalence of death in the African American community is devastating. What would you like for us to know about managing your heart disease in the age of COVID-19?
Well, certainly, we've learned quite a bit, and COVID has exposed us to the vulnerabilities of our communities, whether it's engaging with elderly people, and particularly for this discussion, those that have cardiovascular disease or comorbid conditions, so cardiovascular disease, diabetes, obesity, lung disease that may come from smoking. And the consequences of having those afflictions, and particularly of not having them well controlled, is now shown up, and it's made the headlines across the country in terms of this disparate death rate that's occurred from COVID in and of itself. So what we need to learn is how we can better control these chronic illnesses. And to your point, Rosalind, how can we better control these, and how can we access healthcare in a better way so that we can level the playing field?
Got it. So let me ask you a personal question. I had been a gym rat up until, I guess, the first week of March, until we had a shutdown, and I live in northern New Jersey. And I have not been really exercising the way that I should, and I've been eating a lot of comfort foods. And I really am concerned that I have done or am doing damage to my heart. And, you know, you think you feel palpitations, you're not quite sure. What can you share with me about being of my age, the lack of exercise, and the binge diet that I'm going through? Can I recover from this damage that's taken place over the last 8 weeks?
Fortunately, Rosalind, so you're speaking of risk factors and what COVID has done to your ability to adequately control your risk factors. So I can tell you that you can get them back under control. So these cardiometabolic factors, whether they would be your weight, your blood sugar, your blood cholesterol, or your blood pressure, those things, once you get back in line, start exercising and eating properly again, those will normalize, and likely there will not be any permanent damage. Okay. That being said, with cardiovascular disease, if there is a problem, an acute problem, such as a heart attack or a stroke, it's very important that you seek care, because some of those consequences may not be irreversible. And unfortunately, with the COVID epidemic, the pandemic, people have been avoiding seeking health care when they're having strokes or heart attack symptoms at home, because they're afraid to go to the hospital because they think that COVID is involved there.
Even with that level of pain and discomfort?
They can ride it out.
Ride it out.
That's what it's called. And so, yes, you can ride out. Or what has happened is that sometimes people present in such a late stage that not as much can be done for them, right? So you're aware that with the stroke, that if you get into the hospital within about 3 hours of having stroke symptoms, you can have certain therapies like clot busting medications. But if you arrive after 3 hours, that option is not available for you. So then what you will have is the consequences of the stroke, as opposed to trying to improve the stroke. All right, so we definitely
encourage everyone to be aware and get yourself into care if you're feeling that you have a heart attack or stroke is coming on.
Absolutely. And to your point, to your original question, that those risk factors are what need to be under control for you. And as you say, a gym rat, and what your routine has been, it would be nice to get back into that. Other people, though, say if you had heart failure or diabetes, then they have other concerns in addition to just activity and diet. There may be medications and, say, blood pressure monitoring involved as well. So those individuals need to be more cognizant, be more aware of what's going on, and to try to amp up their control measures, possibly even more than they were doing before, because we don't have the access to health care that we did before the COVID pandemic came through.
So again, just to paraphrase, some people are kind of relaxing, right? Or they're falling back somewhat on taking their medications and like, oh, I don't have to go see my cardiologist. And you're saying
Right.
to fight during this period of COVID-19, we need to even be more vigilant about taking our meds and seeing our physician.
Absolutely.
Understood. If you could just answer for me, what is AFib, and do you see a prevalence of it in the African American community?
Well, AFib is a short way of saying what we call atrial fibrillation, right? And so that occurs when the upper chamber of the heart is just beating very irregular, and it disturbs the efficiency of the lower chamber of the heart pump. The problem with AFib is that, for one, if the heart is not pumping efficiently, you could feel bad. You could feel palpitations, or you could feel weakness because you're not really firing on all cylinders. But the major problem with atrial fibrillation is that in some people, it increases their risk of having a stroke. And I know that we all know that the prevalence of stroke in the Black community is very high. And so anything that we can do to reduce our chance of stroke is worth it, and nobody wants to have a stroke. So oftentimes we will find that when people have had strokes for no good reason, they often have atrial fibrillation. And so we are now trying to do quite a bit to to detect it better. I think that we are finding that atrial fibrillation is much more common in the African American community than we initially suspected. We've always known that it was more common in women than men, but I do believe that hasn't been clearly identified yet in terms of what the reason is. That the reason for people having atrial fibrillation overall, I mean, certainly we can consider certain situations like valvular heart disease, or if you had a virus that hit your heart, then that's very obvious. But for the most part, atrial fibrillation is something that comes on with age. And what we've found is that women are more likely to reach older ages than men are, particularly. Right. So it's a problem for everyone. I don't think that there's much that can be done to avoid it, but it must be recognized if you do actually have it, and then to take action to make sure that you don't suffer any of the consequences, chiefly stroke, but also that it doesn't impede your activity level at all, and you don't have heart failure from it.
So once you've been diagnosed, when do you become a candidate for advanced measures?
Well, that's typically a discussion that you would have with your cardiologist. So there are many things that can be done. The first and most important is to prevent stroke. And that's often done with blood thinning medications. Other things that we think about are trying to control the heart rate so your heart's not fluttering in your chest all the time and basically making you feel fatigued. So then we will control either trying to get you in the normal rhythm, or at least slow your rhythm down to the point that it doesn't bother you, right? The key thing, though, is with the stroke prevention and the blood thinners, because taking blood thinners adds a whole degree of complexity. Some people can't tolerate the blood thinners because they have other conditions, like perhaps stomach ulcers or other conditions that make them more prone for bleeding. And if that's the case, it should be recognized, because now there are additional, more device-related therapies that are available that can prevent your risk of having a stroke and yet keep you at a low risk of bleeding because of blood thinners as well.
Can you speak to us more about the devices? Do a lot of African Americans know about these devices, to ask about the devices, or how do we start to even initiate that type of conversation? And could you just speak to the pros and cons of devices versus taking therapy?
So there are many devices, definitely. So the stroke prevention devices, they aren't widely known for all physicians. And it seems that most primary care physicians are the ones that would manage atrial fibrillation for the most part. Okay. So making them aware of these, and then also to make the referrals for people who can further evaluate this, such as cardiologists that specialize in extra heartbeats, or those that specialize in putting in devices. They're very aware of who would be a good candidate for the devices or not. We're trying to make it more aware to the public, that they understand, so they can have these conversations with their doctor to know that they may need to be referred. And that's the key thing, is that oftentimes primary care physicians may not know where to send someone to have some further investigations performed. And that's what we have to put an individual will have to work with their doctor to understand that just because the doctor may not have the resources within their own office, it doesn't mean that the patient can't travel to get those resources, to get those things done.
Yes, I mean, Doctor, I just want to share, you've also written a wonderful article for us about the fact that devices are often underused in African American populations.
That's very true. So if you think about medications where the doctor writes a prescription and then you go to the pharmacist and get the prescription and then take the pills on your own at home, that's one mechanism. Devices work a little bit differently in the sense that they often have to be put in by somebody. So it often involves going to the hospital or some radiology suite that the device can actually be implanted in you. Understanding that this is more like a minimally invasive surgery, it means that there's a little bit more evaluation that's going to have to take place before you get that specific therapy. Once everything is in, once the device is in, like looking back on it a year later, everything should probably be very good and they're pretty much maintenance free. But there are more steps that one must go through to have them put in. And particularly for some of the more complex devices that we have available for us today, if you consider something like a defibrillator or a heart valve, or even some of these devices that we use for atrial fibrillation, that those are more complicated and we want to make sure that they fit properly. They have to be, fit to that individual. There may be more testing that you need before you actually have the device put in. And it's that sequence of testing that we found that African Americans and other people of color don't complete the sequence of testing, and therefore there are not as many devices put into them. But a key part.
I mean, just to speak personally, my father was a candidate, and my goodness, we could not get him to take the steps to actually be evaluated. I mean, and then once it was diagnosed and it was prescribed that he would have to have a device, it was difficult to get him to schedule the time to have it done because he was intimidated about going to the hospital to having a procedure done. I'm sure you come across that all the time.
Absolutely. And certainly there is trepidation and mistrust of people of color with the medical community, with the healthcare system. And it takes an extreme degree of trust to allow someone to actually put something in your body, right? So what we have to do is to have a closer working relationship between the patients, the people in the public, as well as the healthcare system. And that hasn't always been the case. In the past, the paradigm has been for the person to go to the clinic, like at a hospital, go in, visit a doctor writes a prescription, you go back home, come back in a month, and do that over and over again. Now it's going to be much more up to the individual to pursue the therapies, in the sense that if the doctor tells you need to go across town to get a test, then you actually need to go across town to get the test done. It's not just a matter of going to your doctor back and forth anymore. It's not going to come to your doctor. You would have to travel a little bit to get it. And then you'll also have to make sure that you're able to interact with those different offices. It may not be as comfortable as it was when you're dealing with your own primary care physician.
I understood. So it would be helpful to have a patient advocate or someone with a friend or family member to help you navigate that journey.
Absolutely. And again, the Association of Black Cardiologists tries to provide resources. We have our website, and to provide resources online to help orient people on perhaps questions they should ask or knowledge that they should have before they go in to see the doctor, trying to understand the total perspective of what the doctor is getting at when they're asking these questions. And again, as to your point, a health advocate is extremely important. And we are training health advocates now to be in the community so that they can assist people if questions come up, particularly related to cardiovascular disease.
So, Dr. Underwood, once you have one of these procedures done, you have something installed, can you talk to me about the maintenance? How do you live your life? Do you have to get anything tuned or fine-tuned?
Well, it's certainly not all devices are the same.
Normal, what happens?
So certainly not all devices are the same. So the medical devices, as it relates to us, would be pacemakers, defibrillators. So those are electronic devices, and so those can be tuned and adjusted, and they should be tuned and adjusted to make sure the batteries are good in those. And then when it's time to change the batteries, get the batteries changed, right? Other devices like a stent, a coronary stent, those are put in. They have to heal in place. So taking medications for, a month, 3 months, 6 months, a year. After that, to make sure that it heals in place well without clotting, definitely is very important. So that's good. Other ones like valves, there's now we can replace valves, through minimally invasive procedures. It's similar that you would need to take medicines to make sure that it heals in place properly and doesn't clot. So different devices do work different ways, but typically once the implant is finished and you've healed up from the minimally invasive procedure to put it in, your life is pretty much function free. I mean, you can do pretty much whatever you want. I mean, certainly depending on your condition. So it doesn't really, typically devices don't require the same degree of maintenance as, say, taking a medicine every day would have.
Understood. So can you also share with us, I mean, we're living in such challenging times, but out of it, there will be some advances in health equity. We are seeming like we're woke and we're willing to explore and be more open to education when it comes to our healthcare. What do you see being the trend in 2021? What can we look forward to?
I think that what the coronavirus has done is perhaps made us more virtually aware, just as we're discussing things now online using the internet, that this is going to be a way that medicine is going to take also. So telehealth or telemedicine, being able to interact with your healthcare team from the comfort of your own home is going to be very important. In the same token, there's also the digital divide, which means that people of color, African Americans, have not really been on the internet as much as America overall. And that is going to cause gaps in our ability to access healthcare. So the onus is on us to improve our digital capacity and to embrace telehealth, getting our doctors that are taking care of our community to embrace telehealth as well, and knowing how we can prepare ourselves to have the best telemedicine visit possible.
So in the age of COVID, people are reticent about going to see their doctor. And we're afraid that people just aren't going to keep up with their office visits. Are you recommending that as a culture, we should become more comfortable? At Black Health Matters, we love being out in the community, and we see how people thrive when they're speaking to a physician that they trust and respect. Do you think any of that will be lost through telehealth?
I think that certainly the ability to put hands on individuals is going to become diminished to some degree. Eventually, we will have to see patients. So a patient will eventually need to come in for certain things to be evaluated. But for something like blood pressure management, weight management, or diabetes management, a lot of these can be self-managed at home, right? And so the need to come in to see the doctor may not be there quite. If you can provide that information online, then you don't need to go in. If you have a condition and you don't know what's going on, you need a stress test, and you need an ultrasound of the heart, then yes, you are going to need to go visit the doctor and then have more hands-on discussion and understanding it in that nature. But that's, I think, understanding the initial phase of how to get through the system and navigate the system that's going to have a large component of digital interplay it will be important, and we need to make sure that our communities are prepared to embrace it.
So as we evaluate what types of doctors we may work with, it will be important for us to identify those who have an active practice with telemedicine, telehealth, so that they can better be prepared to diagnose us and to handle some of the challenges should we have other pandemics or other issues.
It's an important factor at this moment. And if you can think about for people who are older who have to rely on other people for transportation and getting back and forth to the doctor, telemedicine helps that tremendously as well. So it's possible that we can have better access through telemedicine than we have at this moment. And that's something that this virus has thrust on us. Certainly when the offices open back, we'll be able to get back into the offices, just as you said, for the hands-on experience. But I think that the telemedicine and telehealth is going to stay here in much more a much more prominent position than it has been in the past.
Excellent. Well, the time has flown.
It has.
29. So, Dr. Underwood, again, Medical Director of Boston Scientific, former President of the Association of Black Cardiologists. We thank you for being here with us this evening to talk with Black Health Matters fans and followers about what to do about heart disease in the age of COVID-19. So, Dr. Underwood, we want to stay in touch.
Absolutely, and thank you, Rosalind, and certainly keep up the wonderful work that you've been doing in terms of getting the health messages out there. It's really much appreciated and much needed for us, but particularly in times of crisis that we're in at this moment.
Thank you so much. All right, good night, Facebook family, and we'll catch you next Wednesday for Get Well Wednesday. We have Dr. Michael Lenore, past president of the National Medical Association. Have a good evening.
Thank you.